By way of introduction, I was for many years working at the University of Alberta. I started the occupational health program at that university and the training program in occupational medicine, which has now trained more Canadian occupational physicians than any other. And I continue to be active in Canada. In fact, I'm registered in Ontario, so I'm actually in a sense, I'm a local physician, but that's stretching it a bit. Wanted to start a little bit by talking about two publications that I was involved in. The first was a book that I edited that is pretty comprehensive. It talks about occupational health in the context of international development and economic development, and it's geared to regulatory agencies, scientists, and above all, senior physicians. And it was published by a major publisher and got a lot of circulation. That's one. The other was a 100-page, really concise, loaded with pictures, simple language, translated into 7 languages, which from there are easily translated into additional languages, and is universally accessible on the website of the International Commission, which is the International Organization for Occupational Health. So I've asked myself many times, which had the bigger impact? And the answer is that I have no clue, and I can't document which had the bigger impact. But what I can tell you is that we need to work on both levels in order to have a sustained impact. We need to have experts who are able to go to authoritative sources and to teach the next generation, and for them to teach the next generation after that, so that we propagate what occupational health, and in this case occupational medicine particularly, is all about. And we also need from the ground up to give people, and in this case owners, entrepreneurs, and managers, the basic information so there's no excuse for not knowing. So the information is there, readily available with guidance on how to solve relatively simple problems. And we need that to be available together with the expert information, because if we lack on either level, we're going to fall flat on our face. Evaluating which is more effective in many ways is beside the point, because we need to converge on these issues and have different ways of approaching them, just as Anya told us in her review of the literature on what works. Now, I've been asked to speak on an international perspective. What is local and what is global is sort of an interesting intellectual issue in dealing with health in general and with occupational health in particular. Because here we are today, my assigned topic is an international perspective, but we all know that occupational health is hyper-local. Prevention occurs in a specific workplace. Behavior culture is determined by peer groups in the immediate vicinity in the community and in the employer's circle of control. So what relevance does global issues possibly have? Well, I think that we can learn some lessons from global health. Most schools of public health have a department of global health, and the definition of global health has been changing over the past several years. And now we use the term local more than international. And the reason we do that is that international implies between two countries. Global implies a comprehensive way of looking at health in terms of the needs of particular groups. Global health implies development economics. It involves addressing regional disparities. It includes issues involving indigenous peoples, rural-urban disparities, and define groups like ethnic groups in a community. So when people talk about global health, they're talking about something that is more comprehensive than just the relationship between developed countries and developing countries, or between developed or developing countries. This has actually been incorporated, interestingly enough, into an academic setting right in this community. York University has a faculty of global health. It's not a faculty of public health. They have made a decision to go with global health, specifically looking at what health issues involve defined groups in a multicultural context. What are their relationships with their home countries or the home countries of their parents? What is the meaning of health-related issues to the different people who live in the Greater Toronto area, which is their natural focus? Well, why not occupational health? There are possibilities here, and a means of accessing these people. Occupational health, of course, is protected in the workplace. As I say, it's hyperlocal, but it's guided by policies and regulations that are provincial in Canada, but motivated by expectations, perceptions, goals that are national. So the global context plays a role in defining expectations, where people are motivated to move in terms of improvement, and perceptions of the priority that occupational health may play. Accountability, responsibility, and implementation, of course, is local, but tracking it, surveillance programs, and so forth are at a larger scale, and we tend to rank ourselves on a national level. Now, here it gets a little embarrassing, because Canada isn't all that great when it comes to our performance internationally. I mean, certainly we're better than most developing countries in terms of our performance in injuries and preventing illnesses, but we're nowhere near the league champions when it comes to performance. The league champions generally being in Northern Europe. There's a lot of room for improvement, and historically we actually never have been at the cutting edge. It's even a little more disturbing too, because on an international level, when you went to international meetings around the world 20 years ago, and I got started in this game about 35 years ago, Canadians were in leadership positions. They were running agencies in the United Nations systems. They were the presidents of international organizations and running task forces. That's very uncommon these days. The only the only global initiative that is led by Canada right now that I'm aware of is Workplace Health Without Borders. Other than that, we have become followers, and I think that is a real shame. Why is it a shame? Does it really affect workers' health on the local level? I would say because of the logic that I just went through, yes. It affects workers' health on the local levels in terms of expectations, in terms of how we're motivated to improve or not, and on the lessons that we learn and share with the rest of the world. Because occupational health is a neglected issue in global economic development on a macro level, but it's also a neglected issue in local economic development on the local level. There's a pattern here. The pattern is partly that we haven't made the connection between global and local, and partly because occupational health is perceived, particularly by employers and by ministries of finance and by treasuries worldwide as a consumptive cost. You basically spend money and you never get that money back because it's basically subsumed into a cost of production. There's no concept that occupational health is an investment, that you get money back, that you get vitality back in terms of the improvement in the quality of life and the productivity and vigor of your citizens. We fall into a dark hole when it comes to proving our worth. And I think that we have to fight that. And the first step in fighting it has to be to recognize that that's what we're struggling against. Now, the issue to me is that the reason that we protect health at work is for people to have better lives, which is the whole reason we produce goods and services to share around the world in order to make our lives better and to do things. Why would we not apply the same principle to occupational health that we do to our economic system? Because preventing disease and injury helps us live better lives, which is supposed to be what the whole point of being able to have services and to buy products is all about. So to me, it's always been the idea that economics and occupational health are somehow competing in allocation of resources. To me, that makes no sense, because the whole idea is for healthy people to live and work better. And we know that from studies of health and productivity, which are best developed in the United States, largely because it's an uphill battle always to prove it to management in the United States. So it's particularly difficult there, and that's why the whole area of health and productivity has become a subset of economics in south of the border. But it really is all about a better quality of life for workers and greater security for workers' families, as well as the employers benefiting from greater productivity and reduced costs. I think that one of the positive things that health and productivity studies have done is they've also told us how to stream occupational health protection into the management system. By arguing about return on investment, we can figure out ways to mainstream the whole logic of occupational health protection into management systems that exist, such as continuous quality improvement. Therefore, we're talking management's language, and we're able to express ourselves in terms and systems that are recognized and routinized. I'm not going to say any more about that, but have a whole set of presentations on that topic. Another issue when it comes to an international perspective is that we have this idea that developing countries are poor countries, and that countries that are struggling to get to middle income and receive the benefits of economic development. No. I think that this slide, which I took from a well-meaning but not necessarily advanced presentation by a junior colleague of mine, all economies and all countries are developing. Just as Canada developed and followed the same pathway of development that poor countries are today, from an agrarian society to a industrial and increasingly to post-industrial societies, all countries and all economies in the world are transforming from something to something else. Manufacturing to a knowledge economy, agrarian to an industrial economy, and so forth. And we have to prepare ourselves for the future and for major changes. Globalization is, of course, as we know, globalization of trade also globalizes inequality, but globalization is part of the efficiencies built into to development, and it's not going to go away. We're going to have to live with productivity without workers in the form of finally automation and robotics and that sort of thing are really taking a bite into employment. We need to figure out how to manage that. There are winners and losers in these economic transformations, and it has revealed to us, these transformations have revealed to us that we as a society, and particularly as an international order, don't respond very well to existential threats. And we see this most clearly in the catastrophic paralysis that we face, largely due to American policies, but not limited to that, in dealing with the existential threat of climate change. But there are possibilities of turning some of these things around. There are opportunities for creative disruption and for investment in solution. Can we do this in occupational health as well? Is it possible to follow the path of countries like Finland, and I'll return to Finland in a moment, and make occupational health and worker protection part of the human development that is a mainstay of the economy? Well, I think so. This just goes back to the point where it's kind of disappointing in terms of where Canada ranks on the league tables. But it makes the point as well that we have terrible statistics. We really find ourselves comparing apples and oranges across countries. So getting a clear idea of where we or any other particular country stands is not easy. But as best as we can tell, we seem to be kind of middling in about the same league as many of the southern and central European countries, certainly not on the same par as the northern European countries. There's also a great deal of variation in performance in Canada, with some provinces, Saskatchewan having the lead in fatalities, lead in injuries, Alberta in fatalities, and New Brunswick actually having a declining performance in occupational injuries, where everyone else is doing steadily better by comparison. Reducing these disparities, as well as increasing our rank in the league tables, as well as paying attention not to our relative rank, but the actual performance in actual terms, in absolute terms, I think are motivating. They're important to know where we are in order to push people to do better. Where can we find models on how to do better? Well, there are actually several, and I mentioned Northern Europe as being particularly exemplary in that regard. But there are also more complicated lessons. We all know that Sweden and Finland have been major world leaders in occupational health. We may have forgotten, however, what happened to Sweden. Sweden, after years and years of being one of the great economic success stories of the 20th century, had a banking crisis in 1993 that precipitated a national recession of considerable magnitude. It was very sharp, very deep, and it lasted about 5 years. So the country was thrown into a really unprecedented economic crisis, and it had become used to being quite affluent. Well, during a period of affluence and during a period of sense of cooperation, Sweden committed itself to an unusual bipartite agreement in order to manage its occupational health issues. And this was a compact. And the compact was forged between the National Employers Confederation and the National Confederation of Unions. And essentially, in, I think it was 1952, the Saltsjöbaden Agreement, they negotiated out, hammered out an agreement in which there would be no strikes, there would be labor peace in exchange for a cooperative way forward, in exchange for occupational health and investment in workers' lives and capacity, and including training. Worked beautifully, worked splendidly for almost 50 years. And then when the recession hit, It all disappeared. It all disintegrated. New government, new economic pressures. The Employers' Confederation pulled out. Everything collapsed. And Swedes discovered, to their chagrin, that they did not have a legal framework to invigilate and to ensure that occupational health would carry on. In other words, that essential backstop, the framework that did not depend on voluntary cooperation, was there, and it took them quite a long time to correct that. And in the meantime, they lost, for example, the National Institute for Occupational Health and the National Institute for Working Life, which were axed by the government as cost-saving measures. So Sweden has had a wonderful history. Then bad stuff happened, and it essentially lost a couple generations, although it's now kind of back up to the Northern European standard. Finland took over as being the center of excellence and so forth, and Finland had an interesting history because it actually had a strategy, a three-part strategy, three-legged stool, in which they were going to drive their economy with increased productivity and technological innovation, hence Nokia, which at the time, of course, was quite innovative in terms of process as well as their product, educating their workers and increasing worker productivity directly by investing in human resources and occupational health and in the providing a safe workplace. So this three-legged stool is called the Finnish model, and it was touted quite heavily by people in that country and leaders in occupational health. Unfortunately, they didn't document it very well. So if you actually go online and you try to search for the essential economic analyses that show that this worked, it's very hard to find. On the other hand, I don't doubt that it did, but I just wish that they had done more studies in economics to show that, so the rest of the world could learn from it. California, which not only is where I just came from in terms of my flight, but also where I was born and raised, is unusual in the United States because it looks more European in many ways than American. It has a special dispensation under the law to create standards on its own in both environmental and, under separate legislation, occupational standards, and it does very well. The injury rates are lower. The worker health is quite a bit better. What does it have in common with the Northern European countries? Well, these are countries that have made a conscious decision to take the costs of production and the costs of running the economy that are normally externalized. In other words, that are borne by people who do not benefit from that production, such as people in the communities in terms of environmental health and workers in terms of occupational health, and re-internalize it into the operating budget. That's done in various ways. Partly it has to do with increased levels of regulation, and partly it has to do with fewer tax incentives and so forth. But as a result, these countries and California as a state has a perception of being high tax, high regulation, and yet they outperform all the others. How can that be? And how can that possibly make sense if you are wedded to the politics-based economic interpretations that dominate our media? Well, the reason is that it's an investment in human capital. It's an investment in the real productivity of the economy, and it removes the economic drags that are not obvious. It puts everything on the balance sheet so that for once we can see what the real costs of production are, and we can figure out how to reduce those real costs so that society as a whole surges ahead, having dropped the anchor that was holding it back. I think obviously now we know that the European Union is is the world lead in terms of occupational health. Basic occupational health is a World Health Organization program. Not a great slogan. It's not particularly ringing, but basic occupational health basically has to do with ensuring that a floor, a fundamental level of occupational health exists everywhere. And the way that the World Health Organization has determined is the way forward for occupational disease is through the primary healthcare system. That's problematical, because how are you going to take a physician who's working in the bush, or a primary care physician in a city whose waiting room is full of screaming children and people with other problems, and make them the occupational health experts? Well, that's the reason why WHO has taken that strategy, is because they can't do anything else. The medical care system is essentially the only system available to work with. We need alternatives, and we need to adapt the medical system in different ways in order to play that role. But that's why when we talk about expanding occupational health education, it's much easier to build it on a medical system than it is in other areas of teaching. You can't leverage a medical program off of an engineering program, but you can relatively easily leverage hygiene or safety off of a program that's geared to occupational medicine with the continuing education opportunities and so forth. So it's strategic. That's why I talk about medicine. It's not just because I'm a physician. It's also because that's where the leverage is in terms of access to the educational system and to move things forward. Well, what lessons are there for us here, and for expanding occupational health on the local level? Well, what if we were to look at the globalized community where we live? And I don't live here, but I do have, my wife and I do own an apartment in downtown Toronto. Not downtown, but in Toronto. Here we start to talk about Toronto. We start to talk about a multicultural community that has interests around the world, and that in which occupational health potentially could find a very receptive outreach. What if we looked at all of those students who are applying in droves to the Faculty of Global Health at York University and started telling them, hey, we have a partnership here, maybe with Ryerson and with programs in the excellent program in hygiene at that institution, and start thinking, what could you do in your community, and are you interested maybe in going back to your parents' country of origin and looking at the problems that they have personal knowledge of, that they have that they know about in the community, sharing some expertise, and talking about occupational health, and then come back. And then come back and to begin to build a nucleus, an ever-expanding nucleus of expertise and practice that spans both the past and the future, and that energizes the community with different perspectives, different points of view, different interactions, and motivation, because it's a way of doing good for the country of origin, as well as for the local community. Is it possible to use this global and local link to recruit people to programs to bring new people into occupational health, people with different perspectives, people who speak different languages literally and metaphorically, and who can spread the idea and who will be motivated because of the international or the global connection. Well, I think that that's an interesting idea, and I think that it's worth pursuing. I think that it also is a way, perhaps, of restoring Canadian leadership, bringing us back to prominence. That if people see leadership on an international level and see opportunities, they are more motivated to work locally, to deserve that leadership, and by developing capacity locally, they're more likely to lead internationally, and it becomes a virtuous cycle, self-renewing. So I think that capacity building for Canada, and specifically Toronto, because it's such a multicultural city, is a way of addressing potential local issues as well as making contribution on the world scene. The current president of the International Commission and the former director of the Occupational Safety and Health Agency for the European Union is Giudotti from Finland. And he has an idea, a vision. It's not a plan, it's a vision right now, for this kind of thing, to develop a global center or even an agency, but probably a non-governmental organization that would actually help countries in the actual practice of occupational health. In other words, going beyond training to offer capacity to deploy people who were familiar with particular problems to fix problems and to evaluate and recommend changes as needed. So the thought occurred to us, what if we were to take this idea of Yucatán, of a response center, combine it with Noel Caron's vision for a chair and center of excellence in occupational medicine at an academic level based in Ontario, which, as I explained earlier, necessarily would be sort of centered on medicine, not because of we're tribal, but because of the leverage that allows. What if Yuca's idea were based at this center of excellence, and we were able to mobilize and excite the multicultural community as a resource for global engagement? Well, we could set up a kind of a residence here where improved capacity and quality for Ontario means benefits to the world, which comes back to Ontario and spreads throughout Canada because of Ontario's predominance in terms of economic and political life in the country. Well, the beauty of this idea is that each one of these elements works pretty well on its own. Put the three together, and you might have something here. A real possibility of the mutually reinforcing platform, three-legged stool, that makes some progress and breaks through some issues, and perhaps most importantly, ensures us a new generation of people who come into occupational health with fresh eyes, with cultural competencies, and can move the country forward with the motivation that comes from aspiring to be world class as opposed to doing a little better than we did before. So what does that three-legged stool sound like? Sounds a lot like the Finnish model idea, where you have mutually reinforcing principles that together drive improvement and can be justified not only for improvement in particularly locally, but economic development that takes us into a new stage, a new transformation that is based on quality of human life as a driver for safety and security. So what could stop this? Well, lack of resources, but frankly, in occupational health and safety, when have we ever had sufficient resources? We're pretty good at working with scarcity because that's really what we've had to work with in this field. I don't think that we lack for commitment, and I don't think that we lack for motivation, and this is an idea that may push the motivation and continue it in a different way. You know, if people perceived occupational health as an environmental problem, we would be getting much different reactions. If people perceived accurately that the workplace is a microenvironment and thought of it in the same way that they think of clean air and clean water and conservation in the natural world, we wouldn't be expending a lot of effort in selling the idea and in reinventing wheels. It's I think a great historic lost opportunity that we have not been successful in aligning what we're talking about with the environmental movement, because I think that it actually is fundamentally part of it. Well, I think that we have to be conscious of the opportunities. I think that we need to be to push for steady progress. Individual programs that are intended to make a big splash don't work all that well in our field. What we need is sustainability and steady improvement. We need we need patience and continuous improvement. We need demonstrations of what's actually effective as opposed to what looks good. And I think that we need to ensure that we have a common vision. So if I've stimulated your thinking a little bit in that regard, I think that's great. Whether the vision becomes a reality or not is difficult to control. But without a vision, we'll never get there, and we'll never get to actualize what our real capacity is. I think that fundamentally what we're talking about is protecting workers and protecting workers' families. And protecting workers' families is an important part of the Social Security role, which has been overlooked by the development economists and has been very much overlooked by our peers and decision makers in terms of the value that occupational health adds. And I think that if we keep a focus on protecting the families through protecting the worker, that will go a long way. And I think that protecting families is a core concept that we can use to build on this, because it is fundamentally all about economic security and development. Thank you very much. I hope I haven't gone on too long.